We are starting with the newer anti-VEGF that are present nowadays. So I presented this PPT in my hospital, Deer Hospital, under moderation of Dr. Pushkar sir. Then before understanding what is anti-VEGF, we have to know what is VEGF. VEGF introduction. So VEGF are the molecules that act on the VEGF receptors and lead to various processes. So VEGF reacting on VEGF receptor R2 and leading to angiogenesis, vascular permeability, endothelial cell proliferation and endothelial cell migration. VEGF B and A acting on the VEGF receptor R1 leading to embryonic vasculogenesis. Then VEGF C and D act on VEGF receptor R3 leading to lymphangiogenesis. So these VEGF molecules act on VEGF receptors leading to various processes as we have read, like in VEGF R1 leading to angiogenesis in embryo, hematopoiesis, inflammatory cell recruitment, neuronal survival, whereas VEGF A, B, C, D and PIGF acting on NRP1 and VEGF A, C, D acting on VEGF receptor R2 and C and D acting on third, leading to various processes as we have read. So in the year 2004, first anti-VEGF that came, it was the pegeptinib. The dose was 0.3 milligram per 0.05 ml. It was only one VEGF-A binder. The molecular weight was high, that is 50 kilodalton, and the composition was sodium salt of 28 oligonucleotide moiety, as we can see in the diagram. Then the half-life was 10 plus minus 4 days. Then in 2005, a monoclonal antibody came, that was bevacizumab, also known as Avastin. The dose, it is looking like an antibody, as we all know the structure of antibody. Acts on all the VEGF-A isoforms. Because it is an antibody, it has high molecular weight, 149 kilodaltons. The half-life is also more, 19 days. And after that, in 2006, ranibizumab came in. It was 0.5 milligram per 0.05 ml. We all know that Eccentrix and Lucentis. So the molecular weight of the ranibizumab is 48 kilodaltons. It is a Fab moiety that is produced from E. coli AB fragment. So it has half-life of 4.75 days. Then in 2011, aflibercept came. It is a recombinant fusion protein, as we can see from the structure, that it is made up of Fc domain of the human immunoglobulin G, and the dose is 2 milligram per 0.05 ml, and it is a fusion proteins. It acts on the VEGF A as well as B and PIGF, whereas up till now we have seen that all were VEGF A binder only. Molecular weight 115 kilodalton, and it has half-life of 7.13 days. Then in 2013, conbercept, it is a recombinant protein of VEGF receptor 1 and receptor 2. It has a dose similar to ranibizumab, 0.5 milligram per 0.05 ml, and the speciality is that ranibizumab was binding only VEGF A, whereas conbercept is binding VEGF A, B and PIGF. It has molecular weight of 26 kilodaltons, that is a molecular weight lesser than the ranibizumab, and it has half-life of approximately 4.24 days, that is nearly equal to ranibizumab. So it has more binding sites. Then in 2019, brolucizumab came. And then it is a humanized single chain variable fragment. As we know that fragment has lesser molecular weight than the whole antibody, 6 kilodalton of weight, and it acts on the VEGF A isoforms, specifically VEGF 110, 121 and 165. Then it has half-life of 5.1 day. In 2022, faricimab came, that is the name of Vabysmo. The speciality is that it is a bispecific antibody and it binds VEGF-A and angiopoietin 2. It has molecular weight of 150 kilodaltons. It is the heaviest till now. It is given in a dose of 6 mg per 0.05 ml. Half-life of 7.5 days. That is, first was the bevacizumab. Pagetinib is obsolete now. Bevacizumab that came in year 2005 in the name of Avastin. It, as we have read the dose, 1.25 to 2.5 mg per 0.05 ml. So it is Avastin. Then ranibizumab 0.5 mg per 0.05 ml in the name of Acentrix or Lucentis. Then brolucizumab, dose 6 mg per 0.05 ml. Lumitin in the name of Lumitin, and it has same dose as of ranibizumab, 0.5 mg per 0.05 ml. And then the aflibercept. Aflibercept is Eylea. It has dose 2 mg per 0.05 ml. I've read it is a fusion protein. Coming to faricimab, it is a bispecific antibody. It has dose of 6 mg per 0.05 ml. Know the indications of various anti-VEGF. Bevacizumab is an off-label drug because it was introduced to treat the cancers: colorectal cancer, non-small cell cancer, metastatic breast cancer, renal cell cancer. Ranibizumab was introduced to treat the neovascular ERMT, macular edema following retinal vein occlusion, diabetic macular edema, and myopic choroidal neovascularization. Brolucizumab is used for wet ARMD and diabetic macular edema. Then conbercept for the wet ARMD, CNVM secondary to the pathological myopia and diabetic macular edema. Aflibercept for the wet ARMD, macular edema associated with renal vein occlusion, diabetic macular edema, myopic CNVM, and diabetic retinopathy. Faricimab is well established for the wet ARMD, DME, and RPO. Why faricimab? Because it is anti-angiopoietin as well as anti-VEGF. So anti-VEGF reduce the permeability and leakage, and anti-angiopoietin reduce the inflammation and enhance the vessel stabilization effects. Because by acting on the angiopoietin 2, it lead to the resolution of intraretinal and subretinal fluid because it enhances the vessel stabilization. So what are the advantages of faricimab over other anti-VEGF? It improves the CST, that is called as the central subfoveal thickness, and reduce the injection numbers. So BCVA, that is the best corrected visual acuity improvement, gaining 15 or more letters. Combination therapy or dual targeted approaches with the long-acting capabilities. Superior anatomic improvement with the anti-angiopoietin 2 and anti-VEGF-A treatment versus anti-VEGF monotherapy. So it is a combined molecule, so it has better effect than only anti-VEGF. It has dual pathway as we have read. Thank you.